Hello, this is Dr. Wala and you're watching the up-to-date series. Today we're going to discuss cranial nerve examination and why should you be able to do it as a routine. We're going to review quickly on basic anatomy and function of cranial nerves and clinical examination, and we're going to focus on the clinical significance of each one, examination and updates. Cranial nerve 1, olfactory nerve, composed of olfactory tract, bulb and olfactory nerves at the end, supplying the mucosa of the nasal cavity and paranasal sinuses. It's a pure sensory nerve which divides into two branches, which are lateral olfactory nerves, which are located in the superior nasal conchae, and medial olfactory nerves, which are located along the nasal septum. The abnormalities in the nerve either loss of complete sense of smell, which is anosmia, or decreased ability to detect the smell, hyposmia, or increased sensitivity to the sense of smell, hypersmia, or dysosmia, which is distorted sense of smell or presence of unpleasant smell in the absence of any actual odor, or in other words, olfactory hallucinations, or phantosmia, smelling something that's not actually there. Olfactory nerve assessment done either at bedside or in the clinic. It's performed by asking the patient to pinch or block one of the nostrils while blindfolded or with eyes closed. Then have the patient smell aromatic substances such as coffee, vanilla, or cinnamon. And you should avoid using substances like strong noxious smells such as alcohol or ammonia. You should have the patient identify the substance based on its aroma, then repeat the same procedure on the other nostril. This is done to compare the sense of smell on both sides, and should be remembered that food flavors depend on the sense of smell, not the sense of taste. The olfactory nerve can be damaged through trauma like fracture of the anterior cranial fossa or blunt trauma to the head, which can lead to laceration of the olfactory nerve as it crosses the ethmoid bone. Also, cerebral tumors of the frontal lobe may produce lesions of the olfactory nerve. Infections also can cause damage to the olfactory nerve or lesions to the olfactory nerve itself or along its pathway, which can lead to the following symptoms. Like previously mentioned, anosmia, hyposmia, but laceration of the nerve usually result in anosmia, which is caused by complete laceration of the nerve. More recently, of course, coronavirus pandemic resulted in anosmia or temporary anosmia, which are rapidly recovered by training of the olfactory nerve. Now, heading to the cranial nerve 2, optic nerve, knowing the pathway of the nerve will guide you know which lesion will affect the vision. Here, originating from the occipital lobes, heading to the optic tract, becoming optic nerve, and here coming to the eye responsible for the vision. Each eye have medial and lateral fields of vision. Blindness of one half of each visual field is called hemianopia, or this hemianopia may be homonymous or bitemporal hemianopia. Lesions of the optic tract or optic radiation produce hemianopia of both eyes, called homonymous hemianopia. The lateral half of the visual field, also called temporal field, lateral or temporal. So, loss of the lateral halves of visual fields of both eyes called bitemporal or both temporal hemianopia, resulting from the loss of function of the medial halves of both retina. So, the medial half abnormality affect the lateral half vision, and usually result from pituitary tumors exerting pressure on the optic chiasm. Here is the optic chiasm. Papilledema is optic disc swelling, which is secondary to elevated intracranial pressure. Vision is usually preserved with the acute papilledema, and the return of vision usually occurred after reversal of the intracranial pressure. And finally, the central stoma is a blind spot in the center of one's vision. It usually resulted from the infection or degeneration of the macula of the eye, which usually frequently found in diabetic retinopathy or macular degeneration. It's quickly assessed by asking the patient about any changes in the eyesight recently, or viewing a chart with lines of variable sizes and asking the patient to differentiate some of these lines, or when any other problems in the eyesight has been detected, a referral should be performed to the specialist to ophthalmoscope examination. As mentioned before, knowing the anatomy will help you assess the cranial nerve. Like pituitary gland tumor will press the optic chiasma and so will affect the vision. Also orbital trauma followed by orbital surgery or orbital floor surgery. Care should be taken during manipulation of the orbital contents to spare the optic nerve without injury. And this surgery should be followed by optic nerve examination. Here I want to stress on knowing the nomenclature of the nerve guides to the location, anatomy, and somehow more to the function of the nerve, and easy memorizing of them. So oculomotor have eyeball and have motor or mobility. So it's the nerve responsible for movement of the eyeball. Trochlear somehow means rotation. So it's move the muscle responsible for downward rotation of the eye, which is the superior oblique. Abducent, the ab mean abduction. There is two nomenclature, abduction and adduction. Add means adding to the midline. Abduction, moving away from the midline. So it's move the muscle which is responsible for moving the eyeball away from the midline or laterally. Abduction means lateral movement. So it's responsible for mobility of the lateral rectus muscle. Here cranial 3, oculomotor 4, trochlear and abducent 6, all usually mentioned together, and oculomotor supply all orbital muscle except superior oblique, which supplied by the trochlear nerve, and lateral rectus muscle, which supplied by abducent nerve. Oculomotor also supply levator palpebral superioris muscle, smooth muscles which are responsible for accommodation like ciliary and sphincter pupillae. Also, it's concerned with autonomic function like pupil constriction, lens accommodation, and also eyelid elevation. Paralysis of oculomotor nerve on one side, resulting in paralysis of 3 muscles, medial, superior, and inferior rectus muscles. So the lateral rectus is the only mobile muscle, resulting in external strabismus, or the eyeball affected. The affected eyeball only moves in the lateral direction, which is called external strabismus. This results in visual field of one eye separate from the normal left eye. So the patient have double vision, which is called diplopia. The patient also have ptosis or dropping of the upper eyelid. Also, smooth muscle paralysis resulted from the affection of oculomotor nerve like sphincter pupillae, resulting in negative accommodation and widely dilated pupil, which is non-reactive to the light, as will be mentioned later. The fourth cranial nerve, trochlear affection, results in superior oblique muscle paralysis, which lead to diplopia on looking forward as the eye turns medially on the pull of the inferior rectus. The sixth cranial nerve, abducent, result in lateral rectus muscle being paralyzed, so resulting in unopposed action of medial rectus. So when the patient look forward, internal strabismus occur. As cranial nerves previously mentioned pass in the cavernous sinus, any cavernous sinus lesion will affect and result in signs and symptoms on the ocular function, added to other symptoms and signs like visual loss, proptosis, ocular and conjunctival congestion, elevation of ocular pressure, or ophthalmoplegia, meaning that complete paralysis of all ocular muscles. Also, cerebral tumors that press on these cranial nerves will affect their function. Trigeminal nerve, here by name tri, means having 3 divisions: ophthalmic, maxillary, mandibular, from up to down. supplying the corresponding segments of the face, upper, middle, and lower segments. Trigeminal also takes general sensation from the anterior two-thirds of the tongue through the lingual nerve. Knowing the function, you will easily know how to proceed to assessment of the nerve by passing a cotton wisp over the face, the three divisions of the face, to test ophthalmic, maxillary, mandibular, respectively. Also by asking the patient to clench on his teeth to check the effectiveness or the motor function of the muscles of mastication. Also, palpation of the muscle will help knowing the tone of the muscle and the strength of its nerve supply. The facial comes from its main motor supply to the facial muscles of expression. Here, facial motor supply to the muscles of the face, not sensation. The sensation previously mentioned by the trigeminal nerve. The main motor facial branches are temporal, zygomatic, buccal, mandibular, and cervical branches. The facial nerve also takes sensation from the anterior two-thirds of the tongue through the chorda tympani branch and the lingual nerve. It also secretes motor to the lacrimal gland, submandibular, and sublingual glands. Clinical assessment by asking the patient to close the eye tightly. The affected facial nerve, the patient cannot be able to close the eye, and subsequent eye exposure, which is traumatic to the eye and the cornea. Also by asking the patient to blow his cheek and raising the eyebrows. There is inability to raise the eyebrow, and there will be teeth showing during smiling. The paralyzed side of the face is called the iron side, or in case of bilateral, the iron face, meaning that all the wrinkles of the face or folds are absent. There is no forehead wrinkles, nor nasolabial fold, nor any facial fold. So there will be also drooping of saliva from the angle of the mouth. The anterior two-thirds of the tongue should be tested also for taste sensation. Here is the cerebral hemispheres, upper motor nucleus on both sides, in which the upper part of the face is supplied by both sides. And here is the internal auditory meatus and the stylomastoid foramen inserting to the parotid gland, and then coming as facial branches, temporal, zygomatic, buccal, mandibular, and cervical branches. So when you see the patient with only the muscles of the lower face is affected, so it's upper motor neuron lesion. If all muscles on one side affected, it's a lower motor neuron lesion. Again, by knowing the pathway of the nerve and the affection of it, you can localize the nerve lesion according to the relation with other nerves. Localizing nerve lesion according to its relation with other nerves like abducent or vestibulocochlear, abducent 6 and facial 7, if both are affected, so the lesion in the bones of the brain where both originate together. While if both facial and vestibulocochlear 7 and 8 respectively are affected, so the lesion in the internal auditory meatus where both are located. If patient is excessively sensitive to sound in one ear, so the lesion in the nerve of stapedius, which is branch of facial nerve. Moreover, in the submandibular surgical approach to the face or the neck, care should be taken to avoid injury of the marginal mandibular branch, which is motor branch of facial nerve, to avoid its injury during incision making and elevation. Vestibulocochlear nerve or cranial 8 has two parts, vestibular and cochlear. Vestibular come from the vestibule within the internal auditory meatus and the cochlea within the same region. It's concerned with two functions: balance by the vestibular part and hearing by the cochlear part, so comes the name from it. And it's also called auditory or acoustic nerve, as it's responsible for hearing. This nerve is simply assessed by the tuning fork test, placed on the mastoid process or behind the ear, and also placing the two arms of the fork beside in front of the external auditory meatus, and asking the patient about hearing on each side respectively, and any abnormalities are recorded. The vestibular part of the auditory nerve supply the atrial and saccule, which are sensitive to static equilibrium, and the semicircular canals, which are responsible for dynamic equilibrium, which are both located in the internal auditory meatus. Any disturbance in the vestibular function result in vertigo or dizziness, nystagmus or uncontrollable pendular eye movement. Any disturbance in the cochlear function result in tinnitus or ear ringing, and deafness, which is patient unable to hear the voice, or tuning fork, which should be tested bilaterally. Cranial nerve 9 or glossopharyngeal nerve composed of two parts, namely glosso means tongue, pharyngeal means pharynx, so it supplies both tongue and the pharynx, namely stylopharyngeus muscle. It also supplies the parotid as a secretomotor function, and taste and general sensation from the posterior 1/3 of the tongue. It also receives sensory input from pharynx, sinus, chemambaro receptors. This function also shared with the vagus nerve, in which examination of both together will be discussed later. It also functions swallowing and salivation. Its primarily can be assessed by testing general and taste sensation from the posterior 1/3 of the tongue, and the anterior 2/3 is the function of facial nerve, chorda tympani branch. Here is cranial nerve 10 vagus, means vague or not defined, as it supplies many vital organs, but its integrity usually tested through its branches to the pharynx, soft palate, and larynx. As we mentioned before, glossopharyngeal 9 and vagus 10 are usually examined simultaneously together by asking the patient to say ah sound and checking elevation of soft palate and uvula, move backward in the midline, which is palatal muscles contraction. Also, by touching the lateral walls of the pharynx, the patient will gag, which is pharyngeal muscle contraction. As the vagus nerve supplies the carotid body, carotid stimulation may result in loss of consciousness to the patient. Also, care should be taken during midline neck surgeries to avoid injury to laryngeal branches of the vagus nerve. Cranial 11 or spinal accessory nerve, which mainly supply the sternocleidomastoid muscle and trapezius muscle. Compromised function of sternomastoid and trapezius muscle result in shoulder dropping and difficult arm elevation above the head. By time, result in muscle wasting and difficult arm abduction or lateral movement away from the midline. Consequently, testing this nerve produced by asking the patient to shrug his shoulder against resistance from our hand, our clinician hand. Also asking the patient to moving the head from side to side against resistance from the clinician hand. Rotation to head to one side brings the sternocleidomastoid muscle into action, and shrugging shoulder bring the trapezius muscle into action. The nerve assessment should be considered for patients with penetrative neck trauma for careful assessment, and during surgeries that involve the posterior triangle of the neck to avoid injury of the nerve. Hypoglossal nerve or cranial 12. Hypo means below, glossal means tongue. meaning that the nerve coming from below the tongue to supply the tongue muscles. As it's a motor nerve responsible for tongue mobility, if there is a nerve lesion, tongue tip will be deviated to the paralyzed side on protrusion. In long-standing paralysis of the tongue, wrinkles on the paralyzed side because of muscle wasting will be resulted. So to assess the nerve, patient is asked to protrude his tongue, and any deviation should be recorded, and push his tongue against cheek from inside, and the tongue should be palpated from outside by the clinician hand to test the tonicity of the tongue muscles. Finally, phrenic and accessory phrenic nerves are not cranial nerves. The 12 cranial nerves are already discussed, but injury to this nerve should be assessed or put into mind during assessing patient of multi-trauma. The phrenic nerve arises from the anterior rami of 3rd, 4th, 5th cervical nerves. The high clinical significance comes from it's the only supply of diaphragm muscle, which, if it affected, there will be problem in breathing and airway compromise to the patient. And each half is supplied by the ipsilateral nerve. So, in penetrating neck injuries, if a phrenic nerve or accessory phrenic nerve is involved, paralysis of the ipsilateral half of diaphragm occurred with subsequent positive abdominal pressure that push up the diaphragm on the same side with collapse of the lower lobe of the lung on the same side. The accessory phrenic nerve route from 4th and 5th cervical nerves may be incorporated to the nerve, to the subclavius muscle, and join the main trunk of the nerve in the thorax. Some tips we discussed before nomenclature. Each cranial nerve, the name of the nerve gives you an idea about anatomy, function of the nerve, and you should consider multiple cranial nerve abnormality is a major disease that should be diagnosed quickly and managed accordingly. Some of cranial nerves are afferent, which transmit sensation to the brain or sensory. Some are efferent or motor, which transmits the motor action from the brain to the specific dermatome or muscle. Some are mixed nerves. A study published 2021 described a case of hyperalgesia to the right side of the face with limited abduction of the right eye caused by hepatocellular carcinoma metastasizing to the right cavernous sinus and Meckel's cave and right petrous bone. This was diagnosed through neurological findings and imaging studies. Although this metastasis is rare, but the clinician should be aware when the patient shows neurological dysfunction, especially cranial nerve involvement. MRI is gold standard for examination with referral to neurologist when cranial nerve abnormality is found. So, awareness of cranial nerve assessment help you assess a traumatic or multi-trauma patient and will guide you during surgeries to avoid special or vital structures including cranial nerves or vital nerves in the region. It's a diagnostic aid in the multiple or many syndromes like Ramsey-Hunt syndrome, facial palsy, or trigeminal neuralgia, when you should know the function of the nerve and the dermatomal supply of the nerve. You can diagnose this condition easily. When suspecting anomaly, doing ultrasound and MRI, or better refer to specialist. The update here is a recent case report published 2021 of a female patient presented with neck pain, which rapidly increased within 5 days with vomiting and impaired bilateral vision. All was normal on physical, neurological, and laboratory investigation except for leukocytosis. The provisional diagnosis was cerebrovascular accident, which was suspected. There was normal electroencephalogram, but CSF collected from lumbar puncture showed marked increased leukocytes, which is normally negligible, and decreased glucose content. bacterial or viral infection was suspected, so empirical antibiotics and antivirals were administered intravenously. There was pathological enhancement of various cranial nerves on MRI. After more specific tests and culture, there was high levels of Borrelia infection with subsequent IgM and IgG increase, and then treated accordingly with the following: ceftriaxone 2 grams twice daily for 3 weeks, and follow up 4 more weeks later. She had recovered well without any more symptoms or sick. The link to this article will be found on the description box below, and if you benefit any part of this video, please share the content with your friends and like and subscribe for more videos. Thank you for watching.